Good evening. Welcome. My name is Susan Kim, and I'm the Deputy Director of the O'Neill Institute for National and Global Health Law at Georgetown University. And I wanted to take this opportunity to welcome you to Georgetown Law and to thank our co-sponsors, Doctors Without Borders, for inviting us to participate in this screening of Fire in the Blood. The Institute is part of a vibrant university community studying health issues from a multidisciplinary perspective, which includes Georgetown Law, the Medical Center, School of Foreign Service, and Graduate School, among others. The O'Neill Institute's particular focus is on how law and policy can be used most effectively to promote positive health outcomes in the US and throughout the world. Our research encompasses a number of areas, including infectious and non-communicable diseases, food and drug law, and health and human rights. For example, we recently launched a global health and human rights database in partnership with the Lawyers Collective in India. The database is an online repository of health and human rights case law and legal instruments from around the world, including those on access to medicines, and is freely accessible to all users. As most of you know, access to medicines is a cornerstone of health and human rights jurisprudence, and developing attainable and legal policy solutions for enduring access is an area of particular focus for the O'Neill Institute. So we are especially honored to be co-sponsoring tonight's event. A brief outline of this evening's schedule. We will begin with a few remarks by the director and then move on to the screening of the film, which will take about an hour and a half. After that, our expert panel will discuss the issues raised in the film and take questions from the audience. Because of the large turnout this evening, we ask that you write your questions on the index cards provided and move them up the aisle. I have been asked to let you know there is a happy hour afterwards at the Dubliner, which you are all invited to. It is now my privilege to introduce Mr. Dylan Gray, the director of Fire in the Blood. Trained as a historian, he has a special interest in political stories with significant international and historical components, often involving complex ethical conflicts. Mr. Gray has worked on feature films in more than 24 countries in close collaboration with numerous acclaimed directors, including Fatih Akin, Peter Greenaway, Paul Greengrass, Deepa Mehta, and Meera Nair. In 2005, Mr. Gray founded the production company Sparkwater India, and Fire in the Blood is his first feature-length film as writer and director. Featured at the Sundance Film Festival, the film was nominated for the Grand Jury Prize, and it has won many other awards and accolades. I hope you enjoy tonight's film and panel discussion. Thank you, and welcome to Georgetown Law.
Thank you very much, Susan, and thank you to the O'Neill Institute for hosting us. It's a real honor to be here. I've actually come from India for this and for a screening we had a few days ago at the United Nations in New York, and that was a very special event, and I'm sure this one will be as well. We have a fantastic panel of people I admire very profoundly speaking after the film, so I don't want to take up too much time. Just to tell you a little bit about Fire in the Blood. It really became a sort of a obsession/passion of mine to make this film after I started to find out about the story it tells, and I think a lot of you will see why once the film sort of gets going. I spent 5.5 years making the film, and I've spent the last 1.5 years sort of taking it around and trying to get it seen. And it's been shown in about 40 countries so far. And I've had the great fortune of going to many of those countries and introducing it to audiences and seeing very, very strong reactions. And, I think for certain people really changing their worldview to the extent that they actually get personally very involved in this issue of access to medicine. The film really is about three things. First of all, it's about what I consider to be one of the great crimes in human history, whereby tens of millions of people with HIV were intentionally denied access to low-cost available medication, leading to an estimated 10 to 12 million unnecessary deaths. It's also about what I consider to be deeply, fundamentally flawed and indefensible system whereby pharmaceuticals are developed and commercialized. And finally, it's a warning call that, despite this immense cataclysm that we portray in the film, the groundwork has been laid for something quite similar and perhaps even worse to happen again in the near future, as unimaginable as that may seem. So it was very important, I think, to make the film, first of all, to document this untold story, but also really to make sure that nobody had an excuse to say we didn't know when, in the coming months and years, they're in a position to do something about, stopping a situation where high-priced drugs are causing unnecessary deaths to the tune of hundreds of thousands of lives per week. And there's no exaggeration when I say that. It's also, for me, really never fails to inspire the people who we sort of built this film around, including James Love, who's one of the panelists tonight, who just showed incredible determination to do what they thought was right, even though there were very few people initially in their corner, and it seemed like the most powerful governments and corporations in the world were rallied against them. So, there is hope in this story, and I think we can all take a lesson from that. An example to say, as monolithic as the other side sometimes seems, if you have if your cause is just and you just refuse to give up, you'll often succeed and emerge triumphant in the end. And I think that's something that we can apply in all kinds of areas of life, far beyond public health and access to medicine. So please enjoy the film. I'll be available for Q&A afterwards, along with the panel. And also, once the event is over, I'll be happy to talk to anybody that's interested in having a word with me. So thank you for coming. Traveling tons, or has it been like...
Okay, I think we're all here. Good evening. I'm Jason Beaubien with National Public Radio. Thank you all for coming this evening. We've got a great opportunity now to have a bit of a discussion about some of these issues. This really remarkable film about a really remarkable moment in our recent history. And part of what's so amazing about it is it really gets at an issue that's going to continue to be with us in the 21st century, this question of how do drugs reach the people who really need them, given that such large numbers of those people are not living in the U.S. or Europe or North America. And so it raises many of those questions. But it also is an amazing profile of a really remarkable time when people came together and actually managed to make that happen. I'm here tonight with Representative Jim McDermott from the great state of Congressman from the great state of Washington. You recognize Jamie Love, a couple of years older, but from the film.
Thanks for that, right?
Rohit,
We're all getting old.
Rohit Malpani is the head of policy and analysis for MSF's Access campaign, major campaign in terms of fighting for access for drugs. And the filmmaker himself, Dylan Gray, is with us as well. So it's a great opportunity to hear various perspectives on this issue. Congressman, I'll start with you. How big of an issue is this up on the Hill? Are people talking about the idea of making changes to patents, increasing access to drugs, both in the developing world and also here in the United States?
Well, let me say as a sort of disclaimer, I don't really know why I'm here, because I'm history. When I came to the Congress in 1989, I had just spent 2 years, I'd spent about 7 months in the Congo, which was the epicenter of the epidemic. And I was responsible for all the embassies south of the equator. So I saw AIDS as it was exploding in Africa. I would travel to 26 embassies and saw things and saw the epidemic coming into the mines in South Africa and all of that as in the early days when AIDS was a death sentence. And when I got to Congress, I went and talked to the speaker, and I said, "There's an AIDS epidemic out there, and it's going to affect the whole world." And of course, at that point, if you remember, 1989, AIDS was a gay man's disease, and if you weren't gay, well then, or we could drug user, or maybe a prostitute who was using drugs, but otherwise you weren't going to get it. So most Americans were walking around thinking, this is no problem.
The Haitians as well.
Yeah, well, the Haitians, they came up to New York and made a problem. But what you were looking at was a Congress that had absolutely no interest whatsoever. I could not get any members to go travel with me. The speaker gave me a carte blanche to go to all over the world, and I was in Asia, and I was in Africa, and I was in the Middle East, and I was in South America, and I was in Central America. I saw the epidemic everywhere, and no members of Congress. So I tried to bring the people who knew about it to Washington, D.C. Speaker opened the meeting, gave a speech. We had all the experts from all over the world, and 10 members of Congress in a week came to a meeting. So the level of interest was absolutely zero. It then started to change when Mandela became president of South Africa, and suddenly people became very interested in doing something with AIDS in South Africa, and the antiretrovirals began to come online. For the first time, you had AZT, and then on to all the others. Now, in the early days, before this film, there was an argument about whether you could ever treat anybody in Africa or any third world country because, well, they don't wear watches and they don't know what time it is, and you have to take a drug every 2 hours or every hour or whatever, and it'd be hopeless to do this. Paul Farmer came from Boston, went down into the highlands of Haiti, and made it possible to show that you could deliver Western medicine at a high level in a very remote place. And it began to be understood that, yes, in fact, you could if you designed a system that worked. And then we come to find that the actual taking of 7 drugs became 1. And that whole process that went on over the last years was facilitated in large measure by someone who I would not ordinarily sit up here and say really good things about. But George Bush he gets a hunk of the credit for it. PEPFAR, without PEPFAR, this never would have happened. And we're now we're on the edge of being able to have an AIDS-free generation. If we can keep PEPFAR moving and keep the pharmaceutical companies in using TPP and a few other things to pull back the patent provisions that would allow countries like India to develop their own drugs. One of our biggest battles was that as long as it was in the American pharmaceutical industry and they had the patent, they had to pay American prices. And when we started having Indians come around and say, well, we can make it a lot cheaper, then there was a real tangle, and you'll see it in trade agreements, and we'll probably talk about that here. So that's how we all got to the movie. And I'm sorry I didn't see the movie, but I think I know what happened.
It is quite amazing. I mean, trade agreements are very much on the table at the moment. Even just last week, President Obama was in Mexico renegotiating some of the trade agreements between Canada, the U.S., and Mexico. And one of the main quotes that we put on NPR was Obama coming out and saying that part of what he's doing there is being there to protect American intellectual property rights. And I don't think that is not just talking about DVDs that are getting sold on the streets in Mexico City. Certainly pharmaceuticals are part of that. I'm not sure which one of you might want to talk about that, but right at the moment, maybe Rohit, what are the big issues that are out there around access to medicine and patents that are being discussed and are out there on the table right now?
Well, thanks again for having us here at the panel, and thank you for doing this for everyone. Just to state, I think Representative McDermott's being a bit modest about the work he's doing today. He's been one of the few voices on Capitol Hill that's speaking out about some of the problems we're seeing with U.S. trade policy today, and the fact that this administration is basically right now at this moment in Singapore negotiating a trade agreement that essentially would consign half of the world's population to permanently higher drug prices. So this is a major issue, and we really commend the congressman for being one of the few voices that's actually trying to speak back on this issue. And part of the problem is you reach the end of the movie and you think to yourself, in a sense, perhaps this issue's been solved. But in fact, this is really an ongoing debate, and it's probably becoming more difficult and more thorny, especially with agreements like the Trans-Pacific Partnership. What we see today is the United States is negotiating a trade agreement with basically a range of countries in the Asia-Pacific region, which will permanently increase medicine prices by expanding monopoly protection for medicines and taking away the ability of governments, as you saw in South Africa and in India, to bring down medicine prices to protect public health. And for an organization like Doctors Without Borders, it means that we will be unable to provide treatment at an affordable price to our patients in the future, and we'll have to scale back our operations around the world. So this is a major concern today and one of the big flashpoints in the access to medicines debate.
Jamie, what do you see as other issues besides, moving on past this, past PEPFAR, past the AIDS drugs? You continue to work in these issues. What do you see as some of the examples that are out there right now about drugs that are being debated? What the price should be in one place versus another? What do you see?
Do I press this? No, it's all voice. It's voice activated. Okay, great. I think if you, there continue to be problems, of course, with AIDS drugs, particularly with the newer AIDS drugs, and actually the creation of things like PEPFAR and the Global Fund created an incentive for people to patent drugs more broadly in the poorest countries now. So that continues to be a problem. There's continued pressure on the Global Fund and on PEPFAR to enforce patents in areas continually poor in poorer countries where enforcement levels were not as big as they used to be. But outside of that, if you look at cancer right now today, which is the big, I think that is the flashpoint for trade policy today. You're in the beginning of the film, not the end of the film. I mean, there's almost no access to new cancer drugs in developing countries. My wife here tonight takes a drug that she's stage 4 breast cancer patient. She takes a drug that cost a sticker price in the United States is $3,000 a week. She has insurance, so the price is only to the insurance company is $1,500 a week. There's almost no access to that drug, Herceptin, in developing countries, even though it's been known to be a real game changer for HER2-positive breast cancer patients for well over a decade. So we have a whole generation of women that just don't get access to the drug. There's a woman that came to a hearing last week from Florida. Her father-in-law lives in Egypt. He makes $300 a month. He's taken a drug called Nexavar, which costs $900 a week. He's gone through his entire life savings. She's there to talk to the Bayer representative at this hearing to ask him if they could do something so he doesn't have to sell his family business and they don't have to go into hock to keep him alive. Bayer said no as recently as today. So I think that across the world, there's this question about whether or not cancer is something that people that are poor that have cancer should get access to, and so that's one thing we really are really focused on. Another one is, if you look at the new Hep C drug that Gilead is charging, people are talking about it costs $1,000 a pill, $84,000 for treatment. Here's some simple math: you could eradicate. In theory, it's an infectious disease. You could try and eradicate hepatitis C. This is a pretty good drug. I think a really high percentage of the people that take it are actually cured with it. The problem is it's $84,000 for treatment. There's 3.2 million infected people in the United States. And even if you don't look at new infections, that's $269 billion. I'm going to repeat that. $269 billion would be the cost of treating 3.2 million people with an $84,000 person treatment. And there's 150 million people that don't live in the United States that have hepatitis C as well. So that's a crazy thing about the system. You've got really, really high prices on drugs, and not everyone that needs them gets it. So one of the things people are trying to do, And Joe Stiglitz, the economist, Congressman Sanders, a lot of MSF has been interested in this. We've been interested. A lot of people now are pushing for, and WHO is experimenting with this, delinking the cost of the drug from the cost of the R&D. And I think that's the way forward. The way forward is to have trade negotiations on research and development, on who pays for the development of drugs, but not on the price of drugs. Instead of trying to ratchet the price up, strengthen the monopolies, and just create all this sort of financial distress and actually kill people in a lot of cases or frustrate treatment objectives, have the drugs be priced like generics all the time, like aspirin, treat everyone, have universal access to the drugs, but then build different systems for rewarding successful drug developers and paying for the kind of research the NIH does. And so that's the issues that we're working on.
But that, what you're talking about right there, means sort of revamping a lot of what the current system is, right? And it's going to mean government getting involved in research and development at a much higher level than they are.
Well, actually, if you look at vaccine development right now, the companies they're paying for less than half of the cost of early phases and phase 4 trials on vaccines. The government's involved already pretty significantly, but it's not a question about having the government invent everything. It's a question of changing the incentives, like innovation inducement prizes, like the Sanders bill for AIDS would give $3 billion a year for people to develop new antiretroviral drugs as a cash reward. There's only been one antiretroviral drug per year for the past 27 years or so. So $3 billion a product is actually not, and that's just for the U.S. market, not the whole world. That's actually a very significant thing. It would be cheaper than the current system by far, but still, it would allow you to actually treat, instead of 40% of the HIV patients in the United States, a much higher percentage. So, but I would say also, if you think you can regulate big pharma, if you think you can regulate the companies, I have a different perspective. I think that the governments don't regulate big pharma. I think big pharma regulates the governments. I think it's the other way around. I don't think you can really regulate big pharma in the public interest. I think you have to blow up the system because it's not working. If you don't have enough data points, it's because you're not looking at the data. I'll stop it.
And this is all really great. I want to ask Dylan a couple of things about the film itself. We were talking just before coming out here, and you were talking about really wanting to show the faces and bring the voices of these people into the film. And you talked about wanting to show the beauty of people's lives, and I think you really do that in the film. I'm wondering if there was, I mean, this is a huge commitment, doing a film like this. I know how much time goes into it, and you've been dedicated to it since then. But was there one particular moment before you started on this film where you said, I have to do this? And was there something that just made it click, that I have to do this?
Well, it was interesting. I mean, I don't actually come from a documentary background. I always worked in more on the scripted, the fiction side. And this story kind of fell into my lap, kind of by accident in a way. I read an article in The Economist, of all places, back in 2004. And it was talking about this fight for antiretroviral medication. And several of the people in the film were in the article, and Dr. Hamid was one of them. And it just so happened that there was a connection between somebody that I was close to and Dr. Hamid, family connection. So I got to meet him. Through him, I met Bill Haddad, the elderly gentleman in the film, who was just a natural storyteller. He's written quite a lot of books, and he's an old school kind of investigative journalist. And I had the good fortune to meet him in Bombay, probably around 2005 or 6, and he really made it clear what a huge story this was to me. And I started sort of just on a personal level, without any intention of making a film, kind of voraciously trying to find things and read about it. And I was just completely startled and shocked to see how little there was actually that I could read and find out about it. And looking for films and books and things, and there were no comprehensive accounts of this story, which seemed so massive to me. And as was mentioned earlier, my training was in history, and I've seen so many times cases that I know well through my research where extremely important things were just lost to humanity because they were not properly documented. And it seemed so obvious to me that this was a case like that. So it really wasn't the filmmaker in me that was stimulated. It was the historian in me, I think, and saw that, holy cow, this is going to be lost. And this is all, it was clear to me the gathering storms were coming together for something possibly even greater and worse to happen. And the lesson had not only not been learned, but I'd say the people that learned the lessons, if you see with TRIPS and some of these trade agreements, it seems very obvious these agreements wouldn't exist if it wasn't for, generic drugs from India actually supplying developing countries. And that's seen as a great threat by Big Pharma, and they want to, eradicate that threat. And they really don't care how many millions of lives or potentially hundreds of millions of lives have to be lost in order to do that. So, at some point, you're asking me, was there a moment? I very well remember the moment. I was actually working on a fiction film that I was supposed to be doing, and I woke up on the morning of June 7th, 2007, just somehow knowing that I had to make this film. So I cheesed a lot of people off by sort of throwing them out of work, and just had decided that, and that just made it my business from that very day forward to do the film. And, I feel very grateful to have had the opportunity to tell this story, because it just, obviously a big chunk of my life has gone into it, but, I feel like, the people in the film, have just sacrificed a lot in order to help their fellow man. And, I think, as I said at the beginning of the program, there's so many lessons in that for all of us. And, so I never felt like it was any kind of sacrifice to do this film. There were many times I felt like I wasn't up to the task, but, I really, at the end, feel very grateful to have had the opportunity.
This film mainly focuses between about 98 to 2003. Is that correct? I'm wondering from maybe Jamie or Rohit, has the world really changed quite dramatically in that decade since 2003? You've got more generic drug producers in South Africa and Brazil, in India. Also, it does seem to me that you're hearing from the drug companies a different dialogue. You are hearing them talking about tiered pricing. Did this fight over ARVs change the landscape? And are we in a different place now in 2014?
I'll give a first response. Of course, we're in a different place today because of the efforts of people that were portrayed in the film. Over 10 million people are on treatment for HIV today, so that's a significant accomplishment. And for our organization, we now have almost 300,000 people on treatment today, whereas, over a decade ago, we couldn't put people on treatment because there weren't the drugs we need. The bigger picture for me, though, is the more things change, the more they stay the same. So you see a lot of gains, of course, in terms of increasing access to treatment for HIV. But we know that our patients are suffering from many other problems. They have drug-resistant tuberculosis. They have co-infection with hepatitis C. As they live longer with HIV, they develop other diseases over the course of their lifetime, like cancer and non-communicable diseases. And for these drugs, there isn't access. Now, one of the things that we talk about a lot in global health is AIDS exceptionalism, the idea that HIV really was the spearhead for a lot of global health initiatives, and I think that's an important advance. But it also means that a lot of other problems that we're facing today are being left behind. And in a sense, the pharmaceutical industry has responded to issues around HIV and AIDS. But we're not seeing any progress on many other diseases, including cancer, because you don't have the same constituency, you don't have the same voice. Patients don't have the same ability to reach out and to express their problems. And that means all of the actions, the very small steps that some governments are taking to try to expand access to treatment for other diseases, is creating a big problem with the pharmaceutical industry and is leading a lot of pressure from the United States and others. The other part of the equation, of course, is around research and development. We still don't have the drugs we need for most diseases that face our patients every day. If a patient has extremely drug-resistant tuberculosis, they have to take 14,000 pills over a 2-year period and still only have about a 15% chance of being cured. It's much more likely than not that they'll die or be permanently disabled. We still don't have drugs in pediatric formulations, so our doctors have to cut the pills in half and hope they work in children. We still don't have vaccines which can work in very tropical environments, so many of the vaccines go bad before we can administer them to our patients, or we simply cannot provide vaccinations. Our medical research and development system doesn't work for our patients. So even if you hear a lot of drug companies talking about increasing access and also improving innovation, they're not really meeting the needs that we have. And in terms of tiered pricing, that is really an industry strategy that's existed over the last decade. That's essentially saying that you charge different prices for different markets depending on the ability to pay. But for us, that's really just a euphemism for charging higher prices and simply targeting that portion of the population in a country like China or India or Brazil that can pay very high prices. the reality is most of the world's poor today live in middle-income countries. 75% of the world's poor today, and that's a big difference from a decade ago. And the industry is saying we're not really going to worry if we can't provide access to that population, because today we see these large emerging market countries as being centers of profit, not centers of poverty.
But ultimately, isn't this an opportunity for the drug companies if they have a Hep C drug, for instance, and they can market it at a certain price outside in the developing world, and by increasing their volume, make more money than they would just selling it in the U.S. at what was it, $100,000 we're talking about for basically a cure for Hep C with this new one from Gilead.
Well, in theory, depending on who sets the prices in tiered pricing, you could imagine something better than nothing but the European American prices for the whole world. I mean, I think that sounds kind of appealing. I think if you look at the details or you look at the problems, let me start with an ATIP, maybe not what you're thinking of, but just talk with Europe, for example. Europe, because it's expanded now, has you may have like a 2-to-1 ratio between like Mississippi and Connecticut. Well, in Europe, it's more like 10-to-1 between some of the Eastern European countries and Northern Europe. There's really big differences in income. Greece is in a crisis right now. So when Greece was trying to get lower prices for drugs, they were being taken off the market in the European Union, and there were stockouts there because people were reselling in other parts of the European countries. So when you start having different prices within an area where there's any kind of trade at all, whether it's reference pricing. Now companies are complaining if they make a discount in Greece, they say the discount price sort of reflects in other European countries and other non-European countries. So they figure every dollar discount they give in Greece costs them like $9 or something. Pfizer did a study a while ago to see if they lowered the price in middle-income countries, would it change their outcomes and their sales, like you say, high volume? And their internal data showed that they would have a 5-fold increase in sales in middle-income countries if they dropped their prices. But they decided not to drop the prices because it was more profitable to sell 1/5 as many drugs at a higher price than 5 times as many drugs at a lower price, because the income difference are really big between the upper class and the lower classes in those middle income countries. So I think you need the NSA, the CIA, the police, everyone else, informants around the block to enforce really the kind of price discrimination that really gives you universal access. Delinkage is a lot simpler model. You go to like Greece, Hungary, Poland, India, different countries. For cancer drugs, what Thailand said is just tell us what fraction of our cancer treatment budget goes as a reward for drug developers. And we'll pay that, but give us the drugs cheap. So they get the drugs cheap, but then you just negotiate, what their end of it is to reward innovators. It's much easier to do that than to police, the so-called appropriate price for a drug like Nexavar, which has, and some drugs have different uses for different indications, or they use for eyes in some cases. I mean, like the Avastin. There's different drugs. It's just a mess when you try and tie the R&D reward to the price. The other thing is, have they changed? Well, one of the problems is that right after the South Africa trial and the big thing, things did change for a while. A lot of people felt kind of embarrassed about, suing Nelson Mandela. Maybe that was a mistake. There was a lot of talk like that. Unfortunately, those guys have retired now. So there's like this new crop of like know-nothing PR people working for drug companies that really want to show their toughness on this issue, and they're bringing it back. And now South Africa has become a brand new target. I haven't seen this for like 10 years. Now, last week and yesterday at USTR, they're all complaining about South Africa wanting to follow India's lead. And so now South Africa has become a target because of the proposed IP reform policies. And so that's kind of scary. So that's part of like just a memory, just a generation thing. So like I got a note from a guy who used to run a big trade association, and he was surprised that Merck was leading the way in South Africa, which was, he said that's what happened in the old days. He couldn't believe they were trying to do it again. Now, the final thing I'd say is that one thing that's hopeful, I think, is that there's now the beginning of a conversation about whether trade can extend not just to private goods, like cars and radios and things like that, but to public goods. And so what people are beginning to talk now is, would it be possible to have a WTO agreement on the supply of public goods? You know, that commitments have fallen off for the Global Fund and things like that. It's hard to raise money for big projects in science and things like that involve multiple countries because people are afraid the other countries won't follow through on their commitments. So the idea is to use the WTO's strong enforcement mechanisms so that a commitment to supply the Global Fund or a big R&D project or something like that, peacekeeping mission, environmental project, climate change, whatever, would become backed up by the enforcement provisions of the WTO. And I think that's an important thing, as are some of these struggling efforts at the World Health Organization to have agreements on funding R&D.
Can I put an or in for the real world? This is a country in which, under Mr. Bush, we put in a drug benefit for senior citizens, and we told the Secretary of Health and Human Services, you may not negotiate lower prices. They will pay retail. Now, the Veterans Administration, that's for 40 million or 50 million people in Medicare. In the Veterans Administration, you have negotiated prices that are almost 50 to 60% less than the seniors are paying in this society. That's the impact of pharma inside the United States. And when Mr. Obama comes along and says, and I'm going to cover another 21 million people, and we're going to have the same Secretary Sebelius with her hands tied, she cannot negotiate a fixed price. She's going to be buying for 80 million people and can't say to a big pharma company, you know, couldn't you bring it down 10% or 20% or 30%? So that's the situation you have in the United States, and it is really being sent out through the trade agreements in the same way that that it is in existence in this country. We negotiated the access to drug stuff in a trade agreement in Peru in 2000, I don't remember the year, but not very long ago. And they're back taking it away because the proposals they've tabled in Singapore in this weekend are for basically, let's go back toward big pharma. And we are living in a system where it is total free enterprise. Anything you can get out of the suckers, you get out of them. And as long as that's our political philosophy in this country, it should be that it should be something like maybe a utility model. I mean, we don't let the electric companies do anything they want. We limit them to a certain amount of profit, right? Why should pharma have 100% profit on something or 200% when we only allow VEPCO 5% or 10% or whatever? Is medicine not as valuable as electricity in our society? We're not even debating that in this country. We are simply letting pharma drive the debate in the United States, and they're driving it internationally. And what will happen, and what is happening, and my belief, my fear is, that all the gains we've made in the AIDS epidemic by treating people, we've made it a chronic disease now that you can live most of a normal life in. But we are going to pull back that money, and people aren't going to have access to drugs, and you're gradually going to see a recrudescence of the epidemic if we're not careful. We are right on the node right now in the Congress trying to decide if we're going to fund the PEPFAR and do anything for the Global Fund and whatever. I think that's the real debate that we're having here. It also applies to pharmaceuticals for cancer and everything else, but it is a generic question about how much profit should a pharmaceutical company make. I mean, we don't want them to make nothing, right? Because you got stock in them in your retirement accounts, right? You got Merck and you got Pfizer, so you got an interest. But how much is enough? That's the question.
You've been in Congress for quite some time. Let me put you a little bit on the spot. This administration, how is this administration compared to administrations in the past on these issues?
I suppose I would have to say that on this particular issue, this administration has been disappointing. I had hoped that the first thing we would do when the president came in was we would take that inability of the Secretary of Health and Human Services and get rid of it so that we could reduce the pharmaceutical prices in this country. That we'd allow her to negotiate, because if I'm going to buy two things from you, I can't ask for much of a discount. If I'm going to buy 40 million things from you, I can ask for a discount. And she has enormous buying power if we just turn her loose. And the president not only didn't do that, he extended it to the health care bill that we passed, the Affordable Care Act. So there are some places where I would have to say he has not been helpful.
Dylan, I want to ask you another question. After making this film, did you come away feeling like it is possible for there to be a major change, not just on ARVs, but on drugs in general, and this sort of relationship between the big pharma of the West and the developing nations? Did you come away feeling like that's possible?
I'm fundamentally optimistic, but I think there's going to be a lot of suffering that's going to happen before things really turn. Unfortunately, I have to say, having spent quite a lot of time in different places, talking to people who have interest in this issue, I think this country is the most intransigent in terms of the brainwashing that has gone on, people's belief in the idea of these vast amounts of money spent on research and development by drug companies, the idea that pharmaceuticals are intrinsically expensive. People will sell their house, they'll sacrifice all kinds of things, but they won't question why that drug is so expensive. I think in a way the industry has made a fundamental misstep by attacking countries like India. Because as we showed in the film, that the 1970 patent law in India really was a game changer in terms of, a great, wonderful period of affordable medication and what is really free market competition. I'm always amazed in this topic that you have people on the right side of the spectrum banging the drum for a government-granted monopoly, and people on the left side of the spectrum banging the drum for free market competition. I mean, it's quite absurd. Where else do you find that? But in India, what we've seen is it's not the government that has driven production; it's private generic production. 25,000 pharmaceutical companies in India, about 100 quite big ones, which export to every single corner of the world. I mean, you can't go to any village anywhere in the world where there are not a substantial amount of Indian generic drugs on the shelves. And people in India have become accustomed to medicine being affordable. And unlike, I know in, say, the UK, about 12% of drug purchases are out-of-pocket purchases. In India, it's over 90%. So people are very much aware of the price of pharmaceuticals, and they're shocked by some of the prices that are coming now, since the country has been TRIPS compliant with the patent law, meaning that some of the cases Jamie's worked on, where these drugs will come in which cost tens of thousands of dollars per month, and the companies will have the cheek to claim that that's the affordable third world price. Prices which are 50, 60 times per capita income. The Indian government is not doing anything out of a sense of altruism. They know very well the effect of pocketbook issues on the population. When the price of onions goes up, when the price of petrol, electricity, it causes major disruptions in the country. And the people in India, 80% of the people in India live on $2 a day or less. They have very, very little disposable income. And when it comes to health problems, there's extreme sensitivity about matters of price. So fundamentally, I don't think the Indian government can actually back down on this in the long term. If they do, they'll see very quickly the error of their ways. There'll be a major upheaval in the country. And, if India doesn't back down, then at some point, some of these other countries will also, take courage from that, whether it be Brazil and Thailand, countries that have done a lot in the past for their own populations, but, in a way are leaders for their whole regions. South Africa, of course, is looking very seriously at emulating the Indian patent law right now. So, I do feel, maybe it's the Indian in me, that that India is the key to this whole question, and I really do not believe in the long term, or even in the medium term, the Indian government can back down on it. They might possibly do so in the short term. I mean, I think our film actually has had quite a big impact in this area, because we, just in November became the longest-running documentary ever in Indian cinemas. The film was very heavily covered in the Indian press, and a lot of people are talking about these issues now. They were blissfully unaware of it before. They didn't realize India played such a major leadership role in this area.
But just to say, it won't be for lack of trying from this administration. I mean, even in the last 2 weeks, we've had multiple instances of very harsh criticism from the administration, as well as from parts of Congress, on the measures that India continues to take to provide affordable medicines. The one trend that I think concerns an organization like ours is increasing tie-ups between multinational companies in the U.S. and Europe with companies in India, in part because their pipelines are failing. They're not developing the new drugs despite record profits over the last couple of decades and expanded intellectual property rules around the world. So they're moving into generic medicines, in a sense. And so the companies that we've relied on in the past are increasingly moving towards other markets. They're looking to simply tie themselves up to multinationals, and they're potentially not going to create the competitive marketplace we need to provide affordable treatment.
Jump in, and then I'm going to get to a couple of the questions. I'm afraid we're not going to be able to get to all of them, but we've got some questions from the crowd as well.
Well, just say, if you look at the political economy problem with all the caps being off, funding elections and things like that, the drug my wife takes generates about $500 million a month for Roche. And if you can imagine, that's just one product of one company. And so what political problem can $500 million a month not solve in the United States these days? So that's part of the problem.
I'm going to go to some of these questions that have come down. The names aren't on here, so I'm just going to read what we've got here. In search of solutions to this problem of access to pharmaceuticals, can you give a voice to an incentive that you think big pharma companies would respond to in allowing the sale of their drugs at generic prices in developing countries? So basically, any of you that want to jump in there, what incentive do you think could really change the way that pharmaceutical companies are interacting with the developing world?
Well, there's a carrot and a stick, and I think the stick that's worked in the period the film covers and until recently is the threat of a compulsory license is what induced people to license their patents to the medicines patents pool, for example, or to make other kinds of concessions. It's really been the threat of losing the monopoly when the government step up. If you want a different kind of incentive, it would really be innovation inducement prizes. The idea that you create an incentive for people to, well, either it's done voluntarily or non-voluntarily. If you do it across a lot of countries, it's probably a voluntary mechanism because you can't legislate everywhere at once. But if you could do it, you can imagine it being done differently.
I want to get to this one here. Compelling movie, but it needs some fair balance. This person says drug patents are intentionally long because it takes greater than 10 years to even begin selling an approved drug. I'm just forward just a little bit. Pharma is spending hundreds of millions of dollars researching, I think it says hundreds of compounds, and then spends over $1 billion to bring a handful of drugs to phase 3 trials. Too many facts were undisclosed in the film to bring an educated and balanced perspective. How would you maybe let Dylan respond to that, and then do you
Yeah, well, I obviously disagree with whoever wrote that. Yeah, if you dig into the figures, even using the industry's own figures, you find that they do actually extremely little basic research. What they call themselves innovators. First of all, they're not willing to innovate their business model. They're not even willing to discuss innovating their business model. So fundamentally, you're not an innovator. Primarily, what we're paying for with our monopoly is clinical trials. And clinical trials are far lower risk than basic research. And, if you do it's quite predictable how much clinical trials are going to cost. I mean, many of them are even outsourced. So if you put all the beans together and see what they're really spending, using their numbers, it would be about 8% of revenue, probably closer to 4% of revenue. We're getting a really bad deal. And what the things that Jamie's talking about, actually putting public money into prize funds or to incentivize actual research would end up costing us way less, and we as societies would have a lot more money to use for other purposes, such as, all-around improvements in healthcare, education, et cetera. So, I think that I strove very hard to be fair. I mean, certainly the film has a point of view. I did a lot of research, spent a lot of time on it, talked to a lot of people, and I do feel, I made a very fair account of the system, which to me is completely indefensible.
Rohit, do you want to jump in on that as
Just
well?
very brief. I mean, even the CEO of GlaxoSmithKline said last year one of the great myths in the pharmaceutical industry is the cost of research and development is $1 billion. He himself said it's, in our opinion, no more than $100 million. Of course, they're highly non-transparent with their R&D costs, but there's other studies that have been done that aren't funded by the drug industry that shows we're really looking at costs between between the $30 and $150 million. Depending on how you measure the figures, half of all research and development is paid for by the public sector, by philanthropies. So the problem is we're essentially paying twice for our research and development. We're putting in for the basic R&D. We're often giving tax credits or public funding for even clinical trials, and then we're simply turning around and paying very high prices. And it goes to this idea that it's very difficult to provide the broad education in the public, because I think there's a very consistent line coming from the pharmaceutical industry that's often repeated in the media as a fact, when in fact there, I think, is a lot of inaccuracy.
If I could just jump in, speaking of pharma CEOs, last year the CEO of Sanofi Aventis, one of the biggest drug companies in the world, the biggest French company, actually said in a keynote address to a major conference that the big pharma should get out of the R&D business because they're not good at it, that they should focus on marketing, which is what they're good at. And I think, that moment of honesty, he came under a lot of attack. He was heavily pilloried for saying that. But, that is something that, when I speak to people from the pharmaceutical industry, off the record, behind the scenes, that theme is repeated again and again. The really good researchers don't want to work for big pharma companies. They do a lot better working in their own sort of startups, or in university settings, et cetera. So, they themselves recognize that the truly talented researchers are not working in their companies.
I was struck by one of the graphics that you had showing that you said that 85%, I believe it was 84% of the drugs were developed publicly, and about 12% of drugs were developed by companies.
Basic research.
Basic research.
Yeah.
I mean, that struck me as very out of sync with my impression. I mean, I cover global health. I get press releases every day from some company claiming, some private company. I don't get press releases from the NIH every day saying that they are developing some new amazing
Well, those
thing.
figures come from Professor Donald Light from Princeton. I was actually, appeared in the British Medical Journal last year, 2012, which is one of the most respected peer-reviewed journals in the world. And that is global funding for basic drug research.
I would point to another source, and that is just in terms of the discovery phase, which is what deals. So the National Science Board of the United States publishes a report called on science indicators, and they break it down by kind of basic research, and then there's like 3 different phases they have. But in the first phase, they put the number, I forget the exact number, right around 85%, very similar number to what Dylan's mentioned. So I think that the clinical trials is really kind of the issue. If you look at the studies that come up with $1 billion number, they don't say they spent $1 billion on clinical trials. What they typically say is that companies may have spent they would claim with some samples, the companies may have spent like $150 million on trials. In Damasi's famous study, I think he had 5,300 patients as his average for the number of patients used for putting a drug through new molecular entities, and some are bigger and some are smaller. But when we looked at all the cancer drugs invented in the last 3 years, which was the biggest crop ever, it was 29 drugs. The average number of patients in trials cited in the press release that the FDA put, and we looked at every single one of them, was less than 500 patients. And 20 of the 29 were eligible for the orphan drug tax credit, which pays for half the cost of the trials. So if you look at these drugs, which are coming in around $100,000, you are not going to be able to find a receipt that shows that they spent very much money on those particular drugs.
We've got a question here saying ART is an effective intervention to diminish transmission and thereby reduce HIV incidence, but this wouldn't be the case for non-communicable diseases. Would the same argument that was made in the film be less effective for anti-cancer drugs? And I think what this person is getting at is basically that to some degree there was a moral imperative here in the AIDS fight to be dealing with what was a disease that was spreading. Is there sort of a division between non-communicable diseases and something like a virus when it comes to trying to make arguments in terms of access to medicine?
I just make a very quick note, Rod, to be much more articulate than I mean, I think what a lot of people fail to do is put themselves in the position of those who are facing these problems. If it was me, if it was my wife, it was my kid, my parent, how would I answer that question? The answer is obvious. You know, I mean, whether it's a communicable disease or non-communicable disease.
Rohit,
I guess just speaking from the maybe first from the organization's perspective, what's interesting for our organization is that we're increasingly finding ourselves in middle-income countries, because of the conflict in Syria, both in Syria as well as in the surrounding countries, to provide treatment and care to refugees and internally displaced persons. And we also find ourselves today in Greece because of exclusion from healthcare due to the collapse of the economy. And there we're seeing, again, the problems of non-communicable diseases. And as an organization of doctors, it's to say the same thing as patients. We simply are there to treat people with what they're afflicted by. So we make no distinction between whether somebody's afflicted by HIV or by cancer or by heart disease. I think what's interesting, to go back to one of your questions about have things changed, what we do see from policymakers and drug companies, in the United States, let's say, is in the European Union, is sure, we understand these problems with HIV, TB, and malaria, and we want to do good. So let's make sure these rules don't create problems for access to these drugs. Let's make sure we have the financing for it. But the minute you bring up anything outside of those three diseases, it's as if the door's shut, and if everything changes, and it's this, it's really this just contradiction. It's this double standard, because we know that the efforts that are being made to address non-communicable diseases, both in terms of prevention and treatment today around the world, and the fact that we can turn to countries which really are going to suffer the worst impacts, where 80% of the impacts of non-communicable diseases lie, really is difficult to square.
Congressman?
I think one of the things that, as I listen to this, what you're hearing is that the basic research is done at public expense. Much of it done through the National Institutes of Health and other similar kinds of programs. And when I came to Congress 25 years ago, there were 100 grants proposed, 19 of them were funded. Today, 100 grants are proposed, and 6 are funded. So we have reduced by 300%, or however you want to look at it, our amount of money that we are investing in basic research. Now, if you don't have basic research, then you don't have the drugs to hand to the pharmaceutical company to do their trials on. And what you're getting from a pharmaceutical company today is very often a drug that they've been 14 years or whatever on their patent, and now it's getting near the end, so they take it into the laboratory and they add a bromine ion or a chloride ion or whatever, a hydroxyl, and then they put it out again using the same research that made it good the first time. They run it again, and they now got 14 more years with essentially the same drug. That's what these clinical trials are largely to just be sure that this new ion that they've put on doesn't mess it up or doesn't do some real damage. But there's no basic research being done in this country by any pharmaceutical companies. It's all being done on private expense, and we are reducing it. The sequester, where we cut down, we just went across the board and cut people, put people out of work all over the country in the laboratories. And what it's doing, even worse long term, is that people who would go into these fields are saying to themselves, why should I take get a PhD, spend 7 years and go $100,000 in debt to come out at the other end, and there's no money for research? Why should I do that? I think I'll go into something else. So you're having some real serious social changes that are going on with this sort of de-emphasis of the public investment. And the folks who are running this place right now are talking about private sector should do it all. We don't need the government. What does the government do? The government makes it possible for all of this to operate.
This gets at how this issue is incredibly complicated, however, because part of what's on the table here is that there have been major problems, there are major health problems in the developing world which are not being addressed by the private sector. And yet, it sounds to me like, from what you're saying, if the U.S. government was involved in had the responsibility to be developing those drugs, there would probably be even less interest in putting that money into research and development for conditions that mainly affect people in the developing world. I mean, do you think that's true, that on Capitol Hill there's not going to be a lot of interest in funding a project that's solely going to affect, say, Chagas or some other neglected disease that only affects people in the tropics?
All you got to do is look at all the caucuses for Crohn's disease and for this disease, all diseases of us here in the Western world, primarily in the United States, but the Western world generally. And those organizations are driving the research agenda. The only reason the AIDS epidemic got the place it did was because of it was a real epidemic and people were afraid it was going to come here. And suddenly they figured, we got to figure out a way to get out of this thing. And we dumped a lot of money in, and now we've made it a chronic disease, and it's dropped off the radar screen in the Congress. Nobody talks about AIDS anymore. Well, there are probably a dozen of us. If you got us all in a room, there are about a dozen who've said something about AIDS in the last 3 months. The rest of the Congress is going blithely on their way, and they do not have any concept of what is out there if we stop treating and pull back on our our prevention. It's very hard to talk about it because it is not sexy. I mean, it's not politically exciting. When you could see pictures of people dying in rows at Mamiemo Hospital in Kinshasa, where I was in the State Department, you'd see 300 people in a room all lying on the floor dying. That stirred people up. We didn't want that to come here. And when people began to realize it might come here, they were willing to put some money in to make something happen. But now...
Jamie, do you want to jump in?
Well, that's a sobering description of the Congress there. But you
don't want to hear the truth. I'll go home.
One of the areas of market failure people talk about today are antibiotics. And it's interesting that in Europe, the president of the head of the trade association for pharmaceutical companies, Bergstrom, has come out and said that you have to come up with something completely different. And he's endorsed delinkage and using innovation inducement prizes is better than the grant of a monopoly for antibiotics, because he says that, as a lot of other people are saying, that with antibiotics, the problem is overprescription and overuse of antibiotics. It contributes to the resistance. And if your reward is like a time-limited monopoly, of course you're going to encourage as much use as possible. So whereas in a new antibiotic, you should sort of reserve and conserve its use, all the economic incentives go the other way. So Bergstrom says, no, you should just write a check when people develop the big drugs and not do the sort of patent monopoly thing. What happened in the U.S. Congress, though? The U.S. Congress, in its legislation, extended the patent life of antibiotics. They kind of went, what could be better than a monopoly, which is like a longer monopoly, I guess, So, but I think, are people willing to pay if they're not threatened with their life? Would they be willing to sort of pay for things? I think certainly there was a point when the NIH budget was doubled, right? There was some interest in that, and I think people care about health. I think that the idea of don't just think about the United States, think about the global thing. The U.S. does pay a lot for research, and people do bike-a-thons, and they do a million different things. They donate money. They have cookie sales to raise money. Fashion shows. Herceptin was done because the Revlon Foundation did a bunch of fashion shows and things to keep the research going on it. Other countries are not as committed to funding innovations as the United States. It seems like rather than say, ramming high prices and longer monopolies on everybody's throat through trade agreements, it'd be more interesting to sort of see more NIH-type activity, more public sector research in different areas. And in fact, it's been recommended to WHO that things move in that direction. People are trying to prime the pump on this. The problem has been that the Bush and the Obama administration in particular has been trying to narrow that agenda down to make it as small and as meaningless as possible instead of the other way around. So, and the Gates Foundation, nobody's really talking much about the Gates Foundation, but the Gates Foundation has been a big, huge problem because they have, sorry about this because I know they're like a, sort of a constituent, but I'm from Bellevue and he's like, he's from my hometown, so, but, they're the biggest donor to the WHO these days, and even bigger than the United States now for discretionary funding. And so they have a lot of sway over there with the Secretariat, and they have lobbied covertly and overtly at different kinds against most of these reforms. And so this whole delinkage campaign, surprisingly to us, one of our biggest problems hasn't been Pfizer, it's been the Gates Foundation, which is doing a lot of good stuff. I mean, they give away billions of money for poor people, but Gates himself is a maniac on the IPI issue. He loves stronger and stronger things, and a lot of stuff is very much focused on these partnerships with the big pharma companies. And it's kind of weird because nobody wants to write about it because everybody in the press, maybe even you, I don't know, maybe not you, but most of the people in the press that cover global health are funded now by the Gates Foundation, BBC, the NewsHour, NPR.
As well.
That's correct. The
Gates Foundation is out there, got their fingers in everything.
That's correct. Yeah, and so so there is the Guardian. It's now their whole site's co-branded by them and things like that. BBC got like 35 million or something from them. So I think that has changed the discourse. So this discussion about intellectual property rights and global health problems, and about the R&D, the delinkage campaign, it's become a very small debate from the news media because most of the news media is reporting on the great successes of the philanthropy supported by the Gates Foundation.
I actually think that's a pretty good place to end it. We have run out of time. Thank you all for coming.
Yes, I do.
Yeah, it's like.
I guess we're done. Pleasure.
Thanks.
Good meeting you. Yeah.
No, thank you.
I will, yeah.
I was sorry I couldn't. I asked, did they get me a copy so I could see it before we did it?
Yeah, I might even have one actually back here. I can give you right now.